Good morning, everyone. I'm so happy to meet you again. Now I am running a private clinic, and in my clinic I am using point of care ultrasound in management by patient. And in these coming series, I will present on almost weekly basis my cases and how can you manage your patient by the help of point of care ultrasound. It will help a lot in diagnosis and in management and in follow-up. It's not only emergency and critical, but also in follow-up and the proper management. And you can consider point of care ultrasound. It's not only important in emergency and critical care, but also in daily practice in every clinic, as you will see in this series. This is the first case. I will present in several lectures because it is a long case and there is a lot of lessons really you can get from this case. Advanced critical care echo hemodynamics 1. Okay, a 61-year-old obese female patient, known case of hypothyroid due to total thyroidectomy and not compliant with thyroxine treatment. She complained of 1 week history of abdominal pain, nausea, vomiting 10 hours ago. Before coming to me, she complained of increasing short of breath, this spell. When I saw the patient in my clinic, she was dyspneic, tachypneic, sweaty, with cold extremities. She looks myxedematous, with pallor, puffy face, hoarse voice, dry skin. On examination, she is hypothermic, 35 degrees centigrade, heart rate 150 per minute, irregular, AF, blood pressure 90-60, chest scattered bronchi, heart rapid AF. We started, this is emergency, patient was really in bad shape. We start by inferior vena cava, and as you see, we saw the inferior vena cava is collapsing. This may be more apparent. You see inferior vena cava, it's totally collapsing in the patient. It's totally collapsing. You see, with inspiration, totally collapsing. Okay, maybe because of 1 week vomiting. We saw the heart, as you see, there was a rapid AF, but really the patient was obese and distressed, and you can completely see all the wall and contractility. You cannot judge the thickening and shortening of the walls of the left ventricles, but you can see this left atrium, which is ballooning, very large left atrium with calcification of the posterior mitral valve leaflets. This gives you a clue about what's going on. This is very rapid irregular heart rate. I cannot judge really the contractility, but this left atrial ballooning denoting that something is wrong and chronic for this patient. Okay, to solve this problem, I tried the parasternal long axis view to get an idea about the thickening and shortening of the wall of the left ventricle, to get an idea about how bad is this left ventricle. Really, it seems to be not good contraction, not good thickening and shortening, and left atrium also here in the parasternal long axis ballooning. Mitral valve is opening well, but to solve this problem and to get a clear idea, you cannot in this very rapid heart rate to assess thickening and shortening in proper way. So in this situation, please, to get an idea about the motion of the left ventricle, you need to fire the M mode to see what's going on. The M mode is very good in spatial clarification. Okay, I fire the M mode. Now it's clear that the anterior septal is not properly thickening, or is not properly thickened, and the inferior lateral wall also is not properly thickened, and shortening is poor. This is the systole and this is the diastole. It's almost, it's not too much different. That means M mode give me a clear picture about what's going on. This left ventricle is thick. I fire the M mode and I did the measurement. The ejection fraction was 26. It's less than 30. That means this patient has bad left ventricular function and ballooning left atrium and rapid AF. This can explain the hypotension and the dyspnea. Here in a mammoth, the left atrium is ballooning more than 4 centimeter. Okay, now you have discrepancy between the right side and left side. You have the inferior vena cava, which is collapsed, totally collapsing and not dilated really on the scales, and the right side, the left side, which revealed ballooning left atrium. That means there is discrepancy between the left side pressures and right side pressures. Okay, and what's important for me, it's not only anatomical confirmation of left ventricular failure, and the left atrial dilatation, but I need exactly to know what about the left atrial pressure. This is very important to me, and this is very important point in management. This patient has AF, so I cannot easily apply the recent diastolic guidelines of American Society of Echocardiography and European Association of Cardiovascular Imaging, because there is no A wave to measure the E over A, and there is fluctuation of the E wave because of rapid AF, and I cannot exactly apply the usual criteria of diastolic failure. So what can I do? According to the American Society of Echocardiography and European Association of Cardiovascular Imaging, in case of AF and left ventricular failure or left ventricular dysfunction, you need to rely on the deceleration time. In general, this is written in the guideline. When the left ventricular ejection fraction is depressed in patients with AF, mitral deceleration time less than 160 millisecond has a reasonable accuracy for the prediction of increased left atrial diastolic pressure and adverse clinical outcome. And there is also another criteria. I will get the easy one here, which is E over E prime. If it's more than or equal 11, it's going with increased left atrial pressure. Okay, in this patient, you will assess the deceleration time and you will assess the E over E prime. E, which is the rapid diastolic feeling of the left ventricle in early diastole, and the E prime, which is the descent of the annulus of mitral valve, septal or lateral, during early diastole. Okay. Back to our patient. Back to our patient. This patient here, rapid AF and very high E over E prime, it's more than 11, and deceleration time, it is less than 160, it's 83. So I have deceleration time very rapid, and I have E over E prime high, and I have left atrial dilatation. So this patient has increased left atrial pressures, and right side there is no increase in pressures. And this sometimes happen. You can sometimes see a discrepancy between the left side pressure and right side pressure, and especially in acute situation like this rapid attack of AF or increase in accelerated hypertension, this acute event may affect the left side and affect the pulmonary circulation and lead to pulmonary congestion, and there is no time to be reflected on the right side and dilate inferior vena cava. This has happened in acute situation. Remember that we will present several cases like that, but get this home message. It's very important. Sometimes there is a discrepancy between left side pressure and right side pressure, especially in acute situation. Starting P line for the patient on the right side, but starting by pressure increase the left side, starting some P lines to appear here, and this explains the increased shorts of breath. Okay, what is the most important management for this patient? You have patient with hypothyroid, non-compliant with medications, and looks hypothyroid, get in rapid attack of AF with ballooning left side, left ventricular failure, increased pressure in the left side, and decreased pressure of right side because of repeated vomiting for 1 week, and now you need to manage. This patient I refer to ICU really, and I need to know from you what is the most important management of this patient, and please document in the comment, and we will go with this patient until you see the patient live at the end. So we have another session to follow up what happening with this patient, but at this session I need you to answer this question, please, and wait me for the next lectures about this patient also. What's the most important management of this patient? In ICU, patient referred to ICU, IV digoxin to control heart rate, followed by IV fluids and anticoagulant, IV digoxin plus IV fluid and anticoagulant, IV beta blocker plus IV fluid and anticoagulant, IV amiodarone plus IV fluid and anticoagulant, IV digoxin plus IV furosemide and anticoagulant. I am waiting for your response, and be ready for the follow up this patient until you see the patient live at the end. Bye bye.